All right, I think we can go ahead and start. Thank you for joining us on this very cold day. I hope everyone is warm and safe out there. I'm Firas Webby, Chief Research Informatics Officer for the Feinberg School of Medicine and Associate Professor of Health and Biomedical Informatics and of Pathology. Welcome to the inaugural Translational Applications in Medical Research lecture, which is co-sponsored by the Lurie Cancer Center and Northwestern University Clinical and Translational Sciences Institute, NUCATS. I serve both communities in my dual roles as in the Quantitative Data Science Core in the Lurie Cancer Center and as the Director of Applied Research Informatics in NUCATS. Many of my colleagues span both communities, working to solve essentially similar problems in complementary disease domains, as you can see from our speakers today. Indeed, as Dr. Platenius has remarked to me repeatedly, cancer research is inherently translational. The new lecture series has been created to highlight path-breaking research and scientific advances by investigators at FSM. The NUCATS Institute and Lurie Cancer Center are committed to accelerating research discoveries to improve human health, and this lecture series is meant to highlight the overlap in achieving this mission. For our inaugural lecture, we are excited to welcome Dr. Seema Kahn and Yuan Luo. Dr. Kahn is the Bloom Family Professor of Cancer Research and Professor of Breast Cancer Surgery. Dr. Yuan Luo is Associate Professor of Preventive Medicine in the Division of Health and Biomedical Informatics and the Chief AI Officer at NUCATS and at the Institute of Augmented Intelligence in Medicine. Both Dr. Kahn and Luo are members of the Lurie Cancer Center and of NUCATS. I will now turn over the presentation to them. Please don't hesitate to type in your questions in the chat, and I look forward to sharing them with our speakers during the discussion time reserved at the end. Please take it away.
So can we have the next slide, please? So I would add to Firas's comments and thank everyone for joining. It's very exciting to be here on the kickoff lecture of this series, which I think will bring really important information about our research activities at the Lurie Cancer Center to our colleagues. And the work that we're going to talk about today is a collaboration between Yuan, Luo, and myself that started a few years ago. And I was very tickled to see but also reassured to see that the SEER database has finally decided to track breast cancer recurrences. So I included this because it was illustrative of the problem that we face in using medical record data to look at long-term cancer outcomes, because cancer recurrences are indeed hard to track. And SEER, reaching almost age 50, has now decided that they should invest the effort into doing this because it is such an important part of developing effective cancer care. Next slide, please. Yuan, are you advancing the slides? Yeah.
Yes.
Okay, so Yuan's going to take over now, I think, to tell you about how we started approaching this problem.
Sure, yeah. So we'll start talking about the first outcome that we started to tackle, and so which is local recurrence. So local recurrence is an event and that frequently is tracked in the EHR records. And so basically local recurrences are breast cancers that occurs on the same site and in the original site of the breast cancer. And so the malignancies, after a while, they started to reappear in the original site, and even after lumpectomy or in the chest wall area after mastectomy. So why this problem is tricky from the algorithm point of view is that, so breast cancer can come back in the breast area where the cancer was originally diagnosed, such as local recurrence. And it also can come back in the regional areas that is close to the original area. So we call that local regional recurrence. And so this local regional recurrence actually creates some ambiguity around local recurrence. And so which increases the difficulty of reliably call out local recurrence. And when evaluating local therapies, local recurrence is actually it's a reliable end outcome. So it's the local recurrence-free survival actually very effectively predict the efficacy of the treatment. And so that poses the question for us. So how can we successfully determine or ascertain the local recurrence based on the clinical reports? And so as Seema mentioned, so this is not routinely tracked in the registry, and the information, although it is in clinical reports, it is not routinely adjudicated and readily available to physicians. So this is our motivation of why we started using machine learning models and natural language processing to tackle this problem. And so to just to give you a brief overview of the current, or what we call previous state-of-the-art approach. So the previous state-of-the-art approach is actually manual chart review. So researchers still heavily rely on the manual chart review to identify the subcohorts with local recurrence event. And the review process, and especially if you are involved in one, is very labor intensive and time consuming. And also it can come with error, especially after people have screened so many reports and become tired. And so how to make this scalable is basically what drives us into developing the machine learning and NLP tool to advance the state of the art. And so in order to identify the local recurrence events from the EHR, so we leveraged the abundant information in the EHR that really makes phenotyping studies achievable. And so we believe that information in the free text in the clinical notes makes NLP very appropriate tool for text mining and actually extract this useful information. And so the ballpark of our motivation really boils down to we want to develop the new tool so that it can be easily replicated and it can readily distinguish local and local regional recurrences for breast cancer. So in order to really extract such information from the EHR system, so we actually looked at which part of the EHR contains the most information about patients' local recurrence. And we found that patients' progressive information and also clinical status are well documented in progress notes. And so as some of you who already looked into progress notes for various other tasks, so progress notes serves to communicate opinions and findings and plans between healthcare professionals. And a well-documented progress note is complete, accurate, and concise for the care delivered to the patients, and including the diagnosis and treatment that are rendered. And progress notes are readily and prevalently available. So almost all institutions, medical institutions, they have progress notes. And the structure of the progress notes, so in this case, is rather freely structured in the sense that there are a lot of natural language sentences in the structure notes. And this seems to be true for many institutions, which actually makes our algorithm interoperable in the sense that it does not have to deal with a lot of the institutional barriers in terms of the templates and also idiosyncratic structures. And another source that we started looking at is the pathology reports. And so pathology reports are frequently generated for recurrent diagnosis, although it is not exclusively for recurrent diagnosis. But one thing that we found out is that, especially for breast cancer, progress report is generated whenever we have a core needle biopsy or surgery that are performed on the patients. And then patients who had a recurrence will ordinarily have 2 or more pathology reports generated in their EHRs throughout the time. And so we naturally think that the number of pathology reports in this case actually serves as a good cue for telling us whether the patient may have a recurrence or not. And in this case, we specifically looked at 120 days as a threshold for separating this recurrent pathology report as the cue. And in order to process the progress notes, which we took their text, we actually relied on the unified medical language system. So as you all know that in clinical reports, the same concept can be expressed as in different ways. So for example, CD45 sometimes is expressed as leukocyte common antigen. And so there are so many ways to say the same thing, which makes the clinical notes rather challenging to process. And so by leveraging on the unified medical language system, we actually were able to map different concepts, their different expressions into the same concept and the same concept ID that are in the UMLS. And so we call such ID concept unique identifiers. And our observation is that in correctly predicting whether the patient has recurrence or not, a few concepts are actually key concepts that if the patient have them, that greatly increase the probability that the patient have recurrence. And so those concept unique identifiers we call positive COEs. And so we developed this positive COEs from 50 women looking at their EHR's progress reports. And then we analyzed the sentences and phrases that are indicative of the occurrence of local recurrence events. And then we annotated them using MetaMap, which basically produce the concept unique identifiers from the UMLS. And then from those development sets, we finally curated 48 COEs that were indicative of recurrence events in breast cancer. And some of those are listed here in this table. And then we want to generate the procedure from progress notes and pathology reports to look at more patients, right? So of course, those positive COEs are identified only from 50 women. So they are not exhaustive, right? But they are very good features. So we actually set out to use them as features and in conjunction with augmented features from the clinical notes and from pathology reports, and then try to combine them in order to improve the accuracy of the adjudication for recurrence. And so the entire process is listed here. And so we first pre-process the clinical notes. The first thing that we did is remove duplicate copies, right? So as a clinician, you often notice that there are duplicated reports, and sometimes there's copy-pasted content. And so it's important to detect those. And then do not let the copy and paste or duplications erroneously magnifies the wrong signal. And then we divide the notes into sentences and then remove non-English symbols and then filter the terms that we extracted from the notes. And the first thing we paid attention to is negation. So sometimes we say that the patient has been ruled out of certain diseases, right? So this is the typical negation. That means that the patient does not have such disease. By correctly recognizing such negation terms, we reduce the false positives that will come out from the algorithm. And also we filtered the concepts that not falls into our positive concept set. So those positive concepts that we developed from the development set is actually quite informative in terms of really indicating the local recurrence event. And after that, we combine any 2 or 3 concept unique identifiers that are extracted from the same sentence. And I'll give an example in the end of why such combination is important when we do the feature analysis. And then finally, we add the number of pathology reports as an additional feature. Recall that we observed that patients with recurrence events, they will often have 2 or more pathology reports. So this is why we use this one as a feature to additionally improve the performance. So here's one of the examples to illustrate the process to generate the features from progress notes. So we have this partial sentence history of recurrent breast cancer. And then by running them through MetaMap, we extracted some of the concepts like history of malignant neoplasm of breast cancer of breast, which maps to this concept ID, and recurrent, which maps to another concept ID, and breast, which maps to another concept ID. And so by using their combination, the intuition is that, so if I just tell you that the patient has breast cancer, or if the patient has a recurrence event, you probably does not know that is the local recurrence of breast cancer. But if I was able to combine all the information that are extracted and mapped to the a concept level, so that is pretty indicative of the patient has local recurrence breast cancer. And here's the intuition plot of the difference in terms of the pathology report numbers as to if you are comparing local recurrence versus no local recurrence. As you can see, the number of pathology report has been quite different if you compare those people have local recurrence versus those people who does not have local recurrence. Their distributions. So here is the raw histograms, and here is the fitted distribution plot, the density plot. And so you can, as you can see, their distribution is quite different, which justifies why we were able to use number of pathology reports as another effective features in determining whether the patient has local recurrence or not. And then we have all those features. The next thing that we do is to build the model and then train, evaluate, and validate the model. And so for this model, we use the supported vector machines. And for evaluation, we split the data into a train set and a test set. And so for those who does machine learning, you realize that we often have parameters and hyperparameters. And so for tuning such parameters and hyperparameters, we did five-fold cross-validation on the training set. And then after selecting the optimal parameters and hyperparameters, we were able to evaluate the system on the held-out test set. And for features, we used combined MetaMap features, which is the UMLS concept unique identifiers that we derived from the text. And we also used the positive dictionary without combination, basically that are those positive clues that we have identified from the development set. And also we used bag of words just in case we have missed anything from our development set. And also just in case that the MetaMap mapping from text to UMLS missed anything in the process. And so this workflow is basically combining the previous development set and then the future derivation set. So I'm not going to spend too much time on this as it just combines the two major steps, but I'll start with the result. And so this is the five-fold cross-validation result. And so this is on 490 double annotated and labeled subjects. One of the project's characteristic that I really wanted to tout is actually the amount of effort that's spent by our students and also our team members into annotating the clinical notes, pathology reports, and progress notes into creating this ground truth, right? So you know that ground truth for machine learning algorithm is very precious, and so reliable ground truth is even more valuable. And so for this purpose, we used a very strict rule saying that we need to have very high inter-annotator agreement. And for that, we calculate the kappa score, and so between any two annotators. And so our kappa score is in the good to excellent range. And so this is why we were able to use a reliable ground truth to train the model. And so now comes to the model in terms of the five-fold cross-validation results. As you can see, different feature combinations give different performance, but those of the performance generally they're in the excellent range. So if you look at filtered MetaMap and pathology report count, so filtered MetaMap basically means that we only focused on the MetaMap CUIs, concept unique identifiers that we identify through the development process. Those are positively associated with local recurrence. And if we focus on those concept unique identifiers and the pathology report counts, we were able to get a 0.93 AUC, and then P, R, and F means precision, recall, and F measure. So those are common metrics when you evaluate any natural language processing systems. And in comparison, if we want to use full MetaMap, so this is what we got. And so Full MetaMap means that you can see that we have a lot of features, a lot more features, right? So those features may or may not be directly related to the local recurrence. And so this is a much richer, but not necessarily always helpful feature set. And so because we have the number of the patients that we had is not like gigantic. So this actually, in our case, actually creates a challenge in terms of really letting machine learning algorithm to figure out which features are really important. So as you can see, there is there is somewhat performance decrease. And then if you look at filtered MetaMap only, and so this actually gives quite a good AUC, and especially when compared to the full MetaMap. And then for background words, those are the most number of features. And so we can see that if we just rely on the words themselves, you actually don't get such a good performance. Your AUC is less than 0.8, which is regarded as the threshold of being good in typical machine learning algorithms. But by leveraging on unified medical language system and also further leveraging on the observation that pathology report count really helps, we were able to boost our AUC on the 5-fold cross-validation up to 0.93. And then this is the held out test set. So we evaluated on 200 subjects, and then we were still able to retain pretty impressive AUC of 0.87. And so those are some of the top ranked features. And so as you can see, some of those features are actually combinations, right? So this one, the second one here, it says there are 2 mentions of the right breast. And so why do you think the 2 mentions of the right breast and in the clinical notes would be helpful in terms of really telling you that the patient has local recurrence? And so I'm going to give you a few examples from the pathology progress notes. And so one example reads, new ductal carcinoma in situ right breast with prior history of right breast cancer. And another sentence reads, this patient underwent needle localization and excision of the right breast 1 week ago after core needle biopsy diagnosis of DCIS on the right breast. And so as you can see, so those are actually from real sentences, those patterns of double mention of the right breast and then DCIS actually are a very reliable cue and highly regarded features by our machine learning model to tell that patient has local recurrence. And so this is our effort of our first attempt on local recurrence of breast cancer. And later on, we have generated the algorithm to start looking at distant recurrence of breast cancer and also contralateral events of the breast cancer. And for more details of the methodology, please refer to those papers cited here. And now I'm going to turn the microphone to Seema and start talking about how we were able to use the data set derived to really derive clinical insights for breast cancer patients.
Thanks very much, Yuan. That was a nice explanation of a complex process that had many levels and took a while to get through. Before I discuss the specific project, I'd just like to point out a couple of things. One of which is the amount of a partnership that it required from the bioinformatics team and the clinical team. So the phases that we went through were an initial sort of teaching period where Yuan and Zeshen, his student, are now very accomplished breast cancer researchers. But when we started out, there was a fairly intense period of information exchange where we learned about what they could do. And we actually taught the team members about breast cancer staging, breast cancer behavior, and the concepts that are important in picking out what we were interested in, which was recurrent disease. And the other thing I'd like to mention also is that this work was possible only because at the time we had support from the Cancer Center in terms of a clinical research coordinator who was based in the breast surgery team and was able to do a lot of the work of the annotation and the building of the ground truth that Yuan mentioned as being critical to this process. So it was actually an iterative process where Yuan and his team took the initial set that we gave them of recurrent disease cases and built their algorithm, then did a search, came back to us. We took a sample of that search and verified by going back to the medical record that the finds, the true positives were in fact true, and so on. So this went through several cycles of testing and retesting before we were able to see the great results that Yuan presented. So the specific question that we applied this data to then, and the data that they generated actually was on almost 7,000 patients that were extremely well annotated now with all of the pathologic features and the recurrence information. And we chose to look at this question of long-term outcomes for breast MRI. So breast MRI is a technique that's been around for a while. It's been used very intensively, but the clinical utility of it, particularly in the surgical planning arena, is in fact questioned and has been for a while. So next slide, please. Yeah, great. So the cancer outcomes that have attracted attention in the application of MRI, actually, most of the publications have addressed short-term outcomes, which are easy to get from the medical record. So this is comparison of the pathologic size with the MRI size or the mammogram size. So this showed that tumor assessment, tumor size assessment was in fact more accurate with MRI. And then there was some other clinical applications like, but I bolded the ones that are particularly addressed by the use of MRI. So that's tumor size assessment, selection of patients for mastectomy because other sites of disease are found in the breast, multicentric disease, which is not visualized on mammogram. And then there was great expectation that the use of MRI for surgical planning would actually also reduce the re-excision rate. So having to return the patient to surgery because the tumor reached the surgical margin, that happens in variably 20 to 30% of women, or did at least until about 5 years ago. So it was expected that the use of MRI would decrease the re-excision rates. And these are the short-term outcomes that have been addressed in multiple publications, and these data are relatively easy to come by. Next slide, please. But the long-term outcomes have been discussed much less often because it is hard to get reliable data on long-term outcomes. And the 3 long-term outcomes that we tried to address was, and I'll only show you the ipsilateral local recurrence data, although we did look at distant disease as well in the work that I'm going to talk about. But these are the 3 groups of important breast cancer outcomes: ipsilateral recurrence, contralateral new disease, distant recurrence, and of course, death. And the hope is that these reduction in the risk of recurrence will also lead to improved survival. Next slide, please. And this one I boxed because this is specifically what we're going to talk about in the breast conservation group. So as you know, breast cancer can be treated with conservation of the breast or mastectomy, and we specifically address breast conservation because that's where in-breast recurrence is the problem. Next slide. So this is, in an ideal world, what we would achieve in a patient with breast cancer who was treated with breast conservation: excellent local control, and there's a question about whether that aids survival or not, but is of value in and of itself. And then obviously optimal cosmetic outcome and a good quality of life that is promoted by being tumor-free. So being tumor-free is an important part of a good quality of life. And it was hoped that MRI would help to achieve these things, but there are clearly disadvantages of MRI. It's costly, very costly, in fact. It's burdensome to the patient. It's a much more unpleasant exam and taxing exam than mammogram, for instance, or ultrasound. It requires the injection of intravenous contrast and so on. It does have a high false positive rate, which leads to unnecessary biopsies, which makes the whole journey of the patient in terms of from diagnosis to surgery more burdensome as well and unpleasant. There is a higher rate of conversion to mastectomy. So many women who've been through the MRI and subsequent biopsy experience, even if the additional biopsies are benign, will opt for mastectomy. And most importantly, there is no evidence to date of improved cancer outcomes when breast cancer surgery is guided by preoperative MRI compared to when it is not. Next slide. Also important is the fact that preoperative MRI use is increasing. These are data from 2005 to 2008, but this trajectory has only continued. In fact, maybe even exponentially increasing. So it is a burdensome and expensive test with no proven improvement in cancer outcomes that is being used increasingly for a wide variety of reasons. And we wanted to address some of the questions related to the benefits of MRI. Next slide, please. So the time trends in local recurrence, when we look at them, even prior to the surge in MRI use, are also very interesting to look at. So this is an analysis of 53 randomized phase 3 trials of systemic therapy in almost, so the meta-analysis yielded almost 100,000 patients. And between 1990 and 2011, so over about 2 decades, the local regional recurrence rate decreased from 30% to 15% of all recurrences in breast cancer patients. So there is a very definite downward trend in the occurrence of local regional recurrence. And there is no interaction between the surgical treatment, so mastectomy or breast conservation doesn't seem to be influencing this, nor the use of radiotherapy. And there are reasons for that that we won't get into today, or the age of the patient, and menopausal status is a surrogate in some ways for the age of the patient. But what does seem to influence it, next slide, please, is the use of systemic therapy. So the blue curve is for chemotherapy, and the green slope is for endocrine therapy. Regardless of what type of systemic therapy has been used over this period of time, there was a very significant decline in local recurrence. Next slide, please. And then this is by margin width. So as I mentioned earlier, one of the benefits of the MRI use was the expectation that wider margins would be achieved, but there's been a lot of discussion about whether wider margins really are beneficial. And next slide. This is the curve for narrower margins, showing a very sturdy decrease in local recurrence over the years. And next one. This is for wider margins, again suggesting that bigger surgery is not necessarily better surgery. So this benefit of MRI may in fact not be that robust because it doesn't seem to matter exactly how wide the margins are as long as they're free. Next slide. So given these factors, there was the trial, there were many trials, not trials, I should take that back, many retrospective analyses published on these issues, and the 4 that are bolded in red are authors who contributed their data at the individual patient level to a meta-analysis that was published in JCO a few years ago. Next slide. And these are the results of the meta-analysis. So regardless of whether MRI was used or not, local recurrence was low in these recent years, as we've seen. And there was no difference in the MRI and the no MRI group. So this is for the overall meta-analysis of all 4 pooled trials. Next slide. And these are the results for individual trials, so really not much heterogeneity between trials. So given these data, next slide, please, and other emerging information about the use of MRI. We reached a point at the Lynn Sage Breast Center in around 2018 when the radiologists and the surgeons agreed that there was no suggestion of preoperative MRI benefit for unselected breast cancer patients. And we had actually had quite a tussle until that time because the radiologists were a lot more enthusiastic because of the radiology literature in terms of the greater sensitivity of MRI, which is undisputed. And the surgeons were a little more reluctant because we wanted to see benefits in terms of longer term outcomes. The shorter term outcomes were not showing clear benefits. So around 2018, we agreed then that for all breast cancer patients, the tendency had been for the radiologist to recommend MRI for most women. And we agreed that this should not be an across-the-board recommendation, but there were remaining questions about young patients because younger women have denser breasts, and also younger women have higher local recurrence risk and more frequent genetic susceptibility to breast cancer. So young age at onset is an indicator of genetic susceptibility. So for a variety of reasons, for the young patients, this remained a question. So this is the question we decided to address using the data that had been generated by Yuan and his team. So this is the algorithm that the radiologists presented to us. Next slide. And I've just circled the area that we then agreed that we would adhere to MRI recommendations from the radiology group. And these were premenopausal women who had dense breasts, unless they had grade 1 DCIS on MRI, because grade 1 DCIS is not well seen on MRI. So then the routine became that we were receiving recommendations for the use of breast MRI in premenopausal women. Next slide. Young patients under 50 or under. So so using the algorithms and the analyses developed by the bioinformatics group, we, from those 7,000 patients that were now well annotated with good follow-up, we identified women who received breast conservation, no, prior slide, please, who received breast conservation, were 50 years or younger in age, also received radiotherapy because that's a big protector against local recurrence. And yeah, I think that's it actually. Received radiotherapy, received breast conservation, were 50 or younger. Next slide. So just looking at the two populations, received MRI or didn't receive MRI, also we restricted it. That's what I was trying to remember. We restricted the population that we included to women who were diagnosed between 2006 and 2013. And the reason we did that is we wanted follow-up after the treatment had occurred so that we could observe these longer-term outcomes. And the reason for not going before 2006 was because MRI use was advancing rapidly, was becoming more frequently used. But there was still a big predominance of women who didn't receive MRI. So the populations were more balanced and the use of MRI had become more stable by 2006. So we were left then with 512 women, and comparing the women who received MRI to those who didn't, there were no great differences between them. The only difference was in follow-up duration because of that imbalance I mentioned. And we saw some residual imbalance in follow-up duration that was significant, but none of the other parameters were significantly different. Next slide. So these are the local and distant recurrence outcomes for this population. And you can see with MRI use, the hazard ratio is very close to 1. There it is completely non-significant. We also performed some sensitivity analyses. We excluded women who didn't have at least 3 years of follow-up, and we excluded women with DCIS, and we found no alteration in the hazard ratio. So looking at both local and distant recurrences in women who did or did not receive MRI preoperatively, we found no difference in these cancer outcomes. Next slide. These were adjusted for other major parameters related to local recurrence and distant recurrence risk. So this is the multivariable Cox regression model. And here too, you see that MRI use was not associated with any benefit in terms of local recurrence risk or in distant recurrence risk. The parameters that were suggestive of an association with risk were related to tumor size, node positivity, both of which were adverse features with larger nodes and larger tumors and positive nodes. And then hormone receptor positivity was protective, and this is all well established in the literature, so these trends are exactly as expected. There were no other significant parameters in the multivariable model. Next slide. So the conclusions of this investigation then were that the use of preoperative breast MRI increases cost of therapy and burden on the patients. There's no evidence of decreased ipsilateral recurrence risk, no suggestion of benefit in contralateral or distant events. There are ongoing trials that may provide better guidance, but they have been extremely difficult to do. Accrual has been very slow, and because of these declining rates of local recurrence, it's actually doubtful whether or not we will see a difference based on MRI use in the randomized trial that's going on in the US. The randomized trial in Britain has not shown any difference, but they are continuing their long-term follow-up. So next slide. So there are remaining challenges. And so I'll just mention before I go on to the challenges that for those who might be thinking that this is a pretty small study of 500 some patients and how much does it really tell us? I should point out that this is the only study that's looked at this at the younger patients, and illustrates again that getting robust data on these kinds of outcomes is actually hard. So despite the studies that I mentioned earlier, no one has really focused on younger patients. And so these are the only data really addressing this specific population. So in terms of remaining challenges in EMR use for cancer outcomes, the biggest one is that we have a leaky follow-up system. So places, the Kaiser Permanente system, for instance, which is much less leaky than ours, or Geisinger in Pennsylvania, they have a much more stable follow-up population. We have a much leakier system, and so if there are areas to address in terms of improving the quality of the data available to us for identifying cancer recurrences, I'm not sure how much that care everywhere information can be used, but there's clearly a need to expand our follow-up data, because I'll show you that there are real problems related to this leakiness. There is a reason for it. Patients come from long distances, and those who are sick may not want to come back here for care. The second new primaries, they require much more complex logic than the ipsilateral recurrences and so on. But retaining patients within the system, and maybe our survivorship clinics will help in that regard, is actually really helpful in terms of getting long-term cancer outcome data. Next slide, please. So this is an example of the problem. So I showed you the data on local and distant recurrence. which is credible, also based on looking at other literature, which corresponds with this. But the survival data was really surprising to us. Can you put in the pointer, Yuan? I have a pointer there. Next slide. So this survival advantage for the MRI group was really surprising to us, particularly given the equivalence in local recurrence and distant recurrence. So this was telling us that women who are treated with preoperative, with surgical planning, aided by preoperative MRI, actually live longer. And after going through the numbers and the survival data in detail with Zeshen, the students we were working with, and sort of looking at the follow-up duration and so on, I eventually decided that these data were biased in ways that we couldn't really understand and couldn't really control for, and also were not biologically consistent with the data. So we did not include the survival analysis. We actually spent a fair amount of effort trying to understand this and to improve the amount of data available. But this is a problem going forward, and this is something we have to think about, ways to fix. It may be more of a problem with cancers like breast and prostate, where survival tends to be longer, maybe less of a problem with things like, pancreas and sarcoma. But it's clearly an area that needs attention, and where the tumor registry so far has not really plugged the holes, at least in my experience, and maybe others have different experience of this, which would be good to discuss. Next slide, please. So we are going to share the conclusions. I think Yuan's going to lead off.
Right, so I can first talk about the conclusions from the methodology perspective. So we found that the sentences in the progress notes and the actual pathology report counts that contains rich information about breast cancer's local or distant recurrences and the contralateral events. Those actually help the downstream analysis, like the preoperative MRI study that Seema has detailed on. And one thing that I'd like to emphasize is that our method that relies on the progress notes and then the pathology report counts is actually quite easy to replicate and does not subject to many of the idiosyncrasies from institutional barriers. So this is actually a choice that is intentionally made. So we know that pathology reports at different institutions may have very different templates, and each pathologist themselves could be actually quite special in terms of how they write the findings. So by not going into the pathology report text, but stay at the count level, so we actually maximize the interoperability, while at the feature level, this is a quite effective features in terms of telling the recurrence events. And so I'll defer the rest of the discussion and conclusions to Seema.
Yeah, so I agree that EMR data is enormously rich, and it can answer a lot of questions and can really expand our horizons in terms of the fraction of the population in a given institution that can be included. So, thinking about our downtown campus and now all of the sites in our network, we have potentially access to very large data sets. But in order to make full use of those data sets, we have to standardize. I mean, the medical record itself is one thing to standardize, obviously. But also, the follow-up algorithms and how follow-up data is collected, because that initial diagnostic data is actually easy to collect. It's in the radiology and pathology reports. It's in the clinic and the operative reports, and There are a discrete number of reports to look at, but when you start thinking about follow-up information that stretches over many years and can come from many different clinicians, it really complicates the problem. So if we develop mining algorithms, I think attention needs to be paid to all of those issues. And then the other thing I think will really help, I mean, using natural language processing obviously is really critical and helpful, but it really begins with the codes. So for all the work we did on this project, where we started was the coding, the diagnostic coding, the procedure coding, and so on and so forth. Even the coding that's done for visits, for return visits. So I really feel, and I try to, educate my young clinicians that are in my purview, the residents and the fellows and the students, that coding is important. It is very critical information for work that you might want to do in the future using the medical record. And if you get in the habit of coding correctly, it is going to make a huge difference to the accuracy of the retrieval of the patients you want to include in your study for whatever research you want to do using the medical record. And then, of course, the EMR designers need to pay attention to research use of data, so that there needs to be a conversation between the people who set up the medical record and not only the clinicians who use it for clinical care, but also the clinical investigators who will use it for research. And I don't know, I mean, I may have an aberrant experience, but speaking for myself, I cannot remember that process has actually happened with any intensity. Maybe Firas can correct me, and I'd certainly like to hear your perspectives on this, Firas, but that's another important aspect. Follow-up of patients who transfer care outside the Northwestern system is, of course, a challenge. And then, as we've already said, clear and continuing communication between the clinical and the bioinformatics investigators is really vital. Next slide. So these are our acknowledgements. A lot of people participated in this. Yuan, do you want to call out anyone specifically?
Sure, yeah. So first, I'd like to start off by thanking the grant supports from both NewCats and Lurie Cancer Center that supports both my team and also Seema's team, and various NIH support. And then I would also acknowledge that our students, which include Zixian, who is now a postdoc at Harvard Medical School. So he really spearheaded the entire effort, leads on not only the program, the coding, but also the actual annotation. So I still remember like looking at those reports with him, and also he looked at like created the annotation guidelines and shared it with all the team members, including those who are listed here. And so I think it's really the convergence of a informatics team with clinical team that by combining all of our strengths and then complement each other, that we could achieve the advancement in both methodology and the clinical front ends at this scale. And Seema, I'm sure you have more to say, and I'll pass on the mic to you.
Right. No, I think I mentioned when I started that that the annotation was possible because of our fellows and our students, but also to a large extent because of the clinical research coordinator who did a lot of this work and was supported by the Cancer Center. So there is a question here about, please describe some examples of discordance between the NLP predictor and ground truth. Why did NLP perform poorly on these cases?
Yeah, so I can take on that question. But before answering that question, I'd like to point out the resource that we created. And so we have created a data mart in the enterprise data warehouse. That data mart contains the structured information that we extracted from the clinical notes together with part of the structured EHR data that are from the original EPIC system. And so we have shared those data on the 7,000 patients in the EDW data mart. And so here the link is the description of what the tables are and what the columns are, and then our inclusion and exclusion criteria, which we actually talked about in this presentation. But I would encourage anyone who are interested in looking at this valuable data set to take a look at this link and then try it out on the EDW system when you have time. And so now I can take the questions that were asked. So the question was describing some examples of discordance between the NLP predictor and the ground truth. So I can give a couple examples on that. So one of the examples that we frequently encountered is, so the original event was mentioned in let's say a progress notes, and then the recurrence was actually diagnosed on the pathology reports, and for some reason the recurrence was only recorded in the pathology reports and not recorded in the progress notes, which actually it should. So in sometimes we found that it could be the progress notes is actually was actually missing before the in the EDW system. Actually, remember that this is before P1, so sometimes that does happen, and so we found those could be the potential reasons, and this makes things complicated. Remember that we were only using the pathology report counts, and so we were really balancing the trade-offs between the interoperability and then including more information to catch more of a recurrence event. So to some extent, it's a double-edged sword, and then we try to find this hard balance. But locally, if we want to additionally include text from the pathology reports, we can actually further include on the sensitivity, which is recall here. And so this is...
Well, sorry to interrupt, but we're hitting the time
Sure.
for this lecture. So, but I just want to thank you for, and I really acknowledge the notion that this is, you know, this is required collaboration, crosstalk, as you both highlighted early on, and also the value of these curated data sets that we need to develop them as these resources to drive innovation and knowledge. Dr. Kahn, I don't know if you know this question, but we do have a question about the age cutoff considered for young patients. Do you know what that was?
Yeah, it was 50.
50. Okay. So yeah, we are at time, and I want to be respectful of everyone's time. I want to thank you all for joining. Please don't hesitate to contact me or the speakers if you have any follow-up if you need any follow-up information. We'll be sure to share the artifacts that came out of this talk today. And thank you all for joining.
Thank you.
Our speakers
Thanks for
again.
organizing it. I hope we can keep talking about this.
Yeah.
Thanks.
Take care. Bye-bye.
Bye.